Hi, everybody. It's 1 minute past the hour, and it is my great pleasure to welcome you all to this International Academy for Clinical Hematology educational webinar dedicated to first-line therapy of Hodgkin lymphoma. This is a topic that continues to exemplify the remarkable progress that can be achieved when science, collaboration, and clinical excellence unite. Hodgkin lymphoma remains one of the most extraordinary success stories in oncology. Once a uniformly fatal disease, it has become one of the true models of curability in cancer. Through decades of clinical research, continuous refinement of treatment strategies, and the integration of biology-driven approaches, we have transformed the prognosis of patients with Hodgkin lymphoma. And today, the majority of the patients are cured, a statement that still stands as an inspiring goal for the entire field of hematology and oncology. However, as with all success stories, new challenges emerge. The quest today is not only to cure more patients, but to cure better, to achieve durable remissions while minimizing toxicity, preserving quality of life, and integrating novel agents and biomarkers into frontline therapy. In this session, we are very fortunate, honored, and privileged to have Professor Ali Bazarbashi from the American University of Beirut. He's also the current chairman of the Lymphoma Working Party of the EBMT. And in this webinar, he will revisit the foundations of cure in Hodgkin lymphoma, discuss how the new modern therapies from PET-adapted approaches to checkpoint inhibitors and other antibody-drug conjugates are reshaping the frontline landscape. And he will explore how we can bring personalized precision to a disease that has already given us so much hope. So, Ali, I'm very grateful and thankful for your presence today, sharing your expertise under the umbrella of the ICH. I hope that after this webinar, we'll be able to have a nice interactive Q&A and continue to learn how the Hodgkin lymphoma story will continue to remind us that curing cancer is possible when knowledge, innovation, and compassion work hand in hand. Ali, the floor is yours.
Thank you very much, Professor Motti, for this very kind introduction. Good morning, good afternoon, good evening, everybody. I'm delighted to give this educational CME lecture on latest updates in frontline treatment of Hodgkin lymphoma, part of the IACH global effort. These are my disclosures. So, as you know, the therapy for advanced stage Hodgkin lymphoma has evolved from single agent chemotherapy in the 1960s to the current targeted and PET response adapted therapy. So you can see on this slide the stars, which were a great success story before the targeted agent with single agent chemotherapy. So to spare patients from the long-term toxicity of large field radiotherapy, to multi-agent chemotherapy, improving efficacy by combining single agent chemotherapy, for example, with MOP, then with ABVD, then intensified chemotherapy to improve upon the outcomes with frontline ABVD, knowing that 30 to 40% of patients progress or relapse at the time, for example, using escalated BIACOP. Then once we cured a large number of patients, these are young patients for the majority of them, and they should have a normal life. More and more evidence accumulated that the major problem in Hodgkin lymphoma is not to cure the patient, because we're curing the overwhelming majority, but long-term toxicities. And then the effort started to try to reduce toxicities associated with intensified chemotherapy regimen. So more recently, in the last decade, we had addition of targeted therapy that started with antibody drug conjugates, brentuximab vedotin, initially with BV-AVD regimen. Then we'll talk about that later. The development of BRICAD, which is a modification of escalated BIACOP, reducing chemotherapy and introducing brentuximab vedotin, to the introduction of checkpoint inhibitors such as nivolumab in the frontline treatment for Hodgkin lymphoma with the Nivo-AVD regimen, improving response and decreasing toxicity. Another important advance in the treatment, in frontline treatment of advanced stage Hodgkin lymphoma, was the use of intermediate PET scan for PET response adapted therapy, with a regimen trying to de-escalate or escalate in the presence of adequate or suboptimal response to the initial 2 cycles of chemotherapy, and then integrating the PET adapted response in the most up-to-date treatments, including targeted and PET adapted response, for example, with BRICAD. And this is a very optimistic slide showing the survival outcomes in Hodgkin lymphoma improving over time. It was not bad in 1975. We were able to have 70% of patients alive at 5 years. In 2017, we moved to 93%, and the results continue to improve since 2017. And the reasons for improvement in survival may include the availability of novel therapy in both frontline, but also in the relapse refractory setting. As we mentioned, the use of PET-CT adapted response, early detection of residual disease and relapse, and importantly, again, strategies to manage chemotherapy-related toxicity using a prophylactic antibiotic, growth factor, dose modification, and improvement in autotransplant outcome for first relapse patient. However, we still have categories of patients that were doing less well with these chemotherapy regimen. So if you see, if you look here on these SEER data on overall survival of advanced stage Hodgkin lymphoma by age, you can see that the 10-year survival exceeded 90% for patients, young patient up to 40. Then we are at around 80% 10-year survival for 40 to 64, but then above 64, survival declined, and we'll see how these results have also improved in recent years for elderly patients. So on this slide, you have the NCCN clinical practice guidelines, and you can see that we have the 4 options that are now recommended for stage 3-4 classical Hodgkin lymphoma. The 2 preferred regimens are nivolumab AVD, 6 cycles. This is together with the BRICAD regimen. We'll talk about both. The BRICAD is a PET-adapted response. Then you have 2 other recommended regimens, BV-AVD with GCSF support and ABVD with de-escalation or escalation. So 2 of these are PET-adapted, the ABVD and the BRICAD, and 2 of these are not PET-adapted, the nivo-AVD and the BV-AVD. So let's start with the oldest PET-adapted approach, which became very popular, the RATTLE phase 3 trial that was updated in JCO in 2024, which support the use of interim PET response adapted approach. So this is a phase 3 trial for patients, adult patients, stage 2B to 4. And you can see that this is a large trial that included more than 1,200 patients. So you have an interim PET after 2 cycles of ABVD. Then patients who were PET negative after the 2 cycles were randomized to 4 additional ABVD or 4 AVD omitting bleomycin. And those that remained PET positive after 2 cycles were escalated to BIACOP or escalated BIACOP. So when we see the long-term efficacy recently reported of the RATTLE trial, you can see the success of the de-escalation with patients PET negative having a 7-year PFS of 81 and 79%, so identical after omitting bleomycin and the associated bleomycin pulmonary toxicity, with a 7-year overall survival of 93%, quite outstanding. For patients who remained PET positive, note that these are a minority of the patient, only 172, so maybe 15% of the whole cohort, or a bit less, 14%. Their PFS was slightly lower, around 66%, and overall survival 83%. Then historically, we had the introduction of brentuximab vedotin replacing bleomycin in a regimen called BV-AVD. And so you have 6 cycles of BV-AVD randomized against 6 cycles of ABVD. Again, this is a quite large study, and you can see the superiority of BV-AVD in terms of progression-free survival, increasing from 74% to 82%, and overall survival significantly increasing from 88.8 to 93.5%. And you can see in terms of toxicity that you had more pregnancies in the BV-AVD arm, for example, and of course, a significant decrease in pulmonary toxicity. When we compare the side effects of both regimens, we have more grade 3 adverse event with BV-AVD, more serious adverse event, but this was in the era where GCSF was not mandatory, prophylactic GCSF. And most of the side effects were febrile neutropenia, sepsis, and infection. And these significantly decreased when GCSF was used. Another important side effect of BV-AVD, but also of ABVD, was the peripheral neuropathies, and their all grade were 43%. So this is not negligible actually with ABVD because of vinblastine, and 67% with BV-AVD. And importantly, peripheral neuropathy, more grade 3 or 4, increased from 2% to 11%. These were reversible, and you can see that the overwhelming majority of patients had total complete resolution of their peripheral neuropathy, but it took time to have that. So now moving to the use of checkpoint inhibitor, nivolumab AVD, in the Nivo-AVD regimen. And you may wonder why Hodgkin lymphoma is so sensitive to PD-1 inhibition. Actually, because the malignant cells, the Reed-Sternberg cells, exhibit frequent copy number alterations of the short arm of chromosome 9 and the genes encoding the programmed DEath1 PD-1 receptor ligands, PDL1 and PDL2. And therefore, this is why Hodgkin lymphoma is much more sensitive to checkpoint inhibitor than other types of lymphoma. And you have checkpoint inhibitors actually have the highest single agent response rate in any tumor type in Hodgkin lymphoma. The SWOG S1826 phase 3 trial actually randomized Nivo-AVD versus brentuximab vedotin AVD. So this is very rare actually to have a randomized trial where you have a novel agent in both arms. This again was a large trial, including around 1,000 patients with stage 3-4 Hodgkin lymphoma. In this trial, you can note that bleomycin was omitted from both arms, and that GCSF was mandatory for BV-AVD and was optional for Nivo-AVD. So patient received 6 cycles of either regimen, and primary endpoint were 2-year progression-free survival. And another specificity of this regimen is that it did not only include, as usual, adult patient 18 to 60, but included pediatric patients 12 to 17, as well as 10% of the patients that were older than 60, and we will see that this is really important. To start with, overall, the PFS was superior for Nivo-AVD versus brentuximab vedotin AVD, with a 2-year PFS increasing from 83 to 92%, and hazard ratio was significant. So the difference is narrowing, but was still significant after over time. And in this forest plot of subgroup analysis, you can see that the PFS benefit with Nivo-AVD was consistent across patient subgroups. So regardless whether we had in pediatric patients, adult patient or older patient, regardless of the IPS, the International Prognostic Score, low IPS 0 to 3 or high IPS 4 to 7, stage 3 or stage 4, with or without B symptoms, all categories benefited from nivo-AVD. Overall survival was similar between the two regimens. So when we look to the cause of death, for the few patients who died, so we had 7 patients in nivo-AVD, 14 in BV-AVD. They died from infection, sepsis, medical issues other than cancer, new primary malignancy, or unknown. And only 1 patient in nivo-AVD out of 500 and 2 patients in BV-AVD out of 500 died from Hodgkin lymphoma, which is quite impressive. So when looking to the adverse events, you can see here that most of the adverse events were grade 1, 2. So we had more neutropenia with nivo-AVD, basically because G-CSF was not mandatory. It was optional, as we mentioned, and it was obligatory with BV-AVD. And we had more peripheral neuropathy in BV-AVD. And for the rest, it was quite equilibrated between the two. So tolerance overall was better with nivo-AVD, despite the use of systematic G-CSF. The grade 3 neutropenia, as we mentioned, were higher in nivo-AVD, but febrile neutropenia were similar, 6 and 7%. Grade 3 infections and were similar, sepsis similar. And when we look to other type of adverse event, you can see that we had more peripheral neuropathy as expected, 32 versus 9, grade 2 or more in BV-AVD, and more thyroid dysfunction, which is a classical side effect of checkpoint inhibitor in nivo-AVD. The rest was quite similar. So when we look to the treatment discontinuation of or death, you can see that we had a little bit more patient discontinuing BV, or 22% versus 9% for nivolumab, and radiotherapy was used in less than 1% of the patients. One important aspect of this regimen, which made nivo-AVD undoubtedly the standard of care in patients above 60, was the difference in efficacy and toxicity in older patients. So you can see that because of impaired tolerance of BV, resulting in delays of treatment, dose reduction, and discontinuation, this had negatively impacted the overall treatment efficacy of BV-AVD in patients above 60. So whereas the difference was significant but small overall, for patients above 60, you can see that the 2-year estimate of PFS was only 64% with BV-AVD versus 89% for nivo-AVD. And you can see on your right-hand side that the dose intensity was lower with BV-AVD compared to nivo-AVD in these older patients. And this has translated into not only improved PFS, but this time we had a significant improvement in 2-year overall survival, increasing from 85 to 96% with a significant p-value. So for patients above 60, Nivo-AVD is now recognized as the first option for advanced stage Hodgkin lymphoma. Another important development in frontline treatment of Hodgkin lymphoma was the report of the BRICAD regimen by the German group. So this is the HD21 phase 3 trial that investigated the intensive frontline regimen BRICAD randomized against escalated BIACOP in patient 18 to 60, stage 2B, 3, or 4. And this is a very large trial with 1,500 patients. So this is a PET-adapted study where we had a PET-CT scan after 2 cycles, and patients that are PET negative, they receive additional 2 cycles of either BRICAD or escalated BIACOP. This happened in 2/3 of the patients. The 1/3 of the patients with BRICAD that remained PET positive received 4 additional BRICAD, and same for escalated BIACOP in the BIACOP arm. And the regimen included radiotherapy in PET positive patient. So you can see that the design of the BRICAD regimen that aims to improve or maintain efficacy of escalated BIACOP while reducing toxicity. So replacing bleomycin with brentuximab vedotin, omitting vincristine and its associated peripheral neuropathy, replacing procarbazine with dacarbazine to reduce secondary malignancy, gonadal toxicity, and serious infection, and maintaining the backbone of etoposide, adriamycin, and cyclophosphamide. So this is the 4-year analysis showing superior progression-free survival as well as treatment-related morbidity with BRICAD after compared to versus escalated BIACOP. So for example, the 4-year PFS increased from 90.9 to 94.3%. So again, where these are really impressive results to have a 4-year PFS above 94% in advanced stage Hodgkin lymphoma. We're talking about PFS, and together with a decrease in treatment-related morbidity from 59 to 42%. In patients aged 61 to 75, the 2-year PFS was also quite good, 91%, and 2-year overall survival, 90%, CR rate, 82%. So, however, I believe that sometimes it's not all patients above 60 can tolerate this intensive chemotherapy. But for those who can, results were really impressive. So, and the PFS benefit with BRICAD versus escalated BIACOP was maintained regardless of PET2 status and across subgroups. So you can see here that in both escalated BIACOP and BRICAD, the PET2 was predictive of long-term PFS, whereby we had better results with for patient achieving PET2 negativity, but numerical benefit of BRICAD were greater in low-risk cohort according to IPS, Ann Arbor stage, and PET2 response compared to high-risk cohort, despite the fact that all subgroups benefited from BRICAD. And this regimen was associated with a significant improvement in quality of life outcome compared to escalated BIACOP, as well as sensory symptoms such as peripheral neuropathy, tingling, numbness of the hands, of the feet, were most frequently reported at restaging after chemotherapy and 3 months follow-up. You can see that a trend toward fewer patients reporting these sensory symptoms with BRICAD versus escalated BIACOP. And as we mentioned, higher functioning and global health status in the first and second year after treatment with BRICAD versus escalated BIACOP. However, you always need to ask your patients whether what is their priority when having multiple efficient, efficacious, and not very toxic regimen. And this is an interesting study where it was shown that physicians may prioritize clinical efficacy and safety over patient goal when selecting frontline treatment of classical Hodgkin lymphoma. This was an online survey. More than 90% of physicians reported discussing treatment pro and con with patients. However, less than 20% reported patient treatment goal to be their first or second most important consideration. So you can see what the physician selected. So clinical trial efficacy and safety, first consideration, 40%, second consideration, 20%. Official guidelines, first consideration, 31%, second consideration, 27%. So we're close to 60%. Patient treatment goal for the physician played a role in less than 20% of decisions, or 9% as first consideration and 10% as second consideration. So how to summarize these findings? Well, the not so old standard management of advanced stage classical Hodgkin lymphoma. So you had 3 options. You had the RATTLE trial, ABVD with escalation to escalated BIACOP, or de-escalation to AVD omitting bleomycin based on the PET-adapted response, or 6 cycles of BV-AVD without PET-adapted response based on the ECHELON-1 trial. And then you had other PET-adapted strategies, such as the HD18 escalated BIACOP, deciding to go for 6 cycles or 4 cycles based on the PET2 results, or the French AHL 2011 trial, starting with 2 cycles of escalated BIACOP and de-escalating to ABVD in responding patient achieving complete metabolic response. For the sake of time, I did not discuss the latest 2 studies. So that was the near past. And now I would say that current management of advanced Hodgkin lymphoma, we should have the 2 options. The SWOG study, the S1826, Nivo-AVD 6 cycles without a PET-adapted response, and the German HD21 BRICAD, and the others are useful in some circumstances, those that used to be the standard of care not so long time ago. I would like to finish with some perspective of what is coming. We have studies investigating combination of brentuximab vedotin with anti-PD-1 regimen. For example, the BV-NIVO AD. This is a multi-center single-arm phase 2 study in treatment-naive patients, bulky stage 1, 2, or stage 3, 4. And the primary endpoint is CR rate at end of treatment. And you can see that we have 88% CR, 93% overall response rate. And we have the ACRO multicenter single-arm phase 2 trial in treatment-naive patients with 8 cycles of BV nivolumab in patients above 60 or unsuitable for standard chemotherapy. So this is a chemo-free regimen. And you can see that we had an overall response of 61%. And finally, we have the Pembro Flash in treatment-naive patient 18 to 60. So it's a phase 2 trial with induction with pembrolizumab, single agent, PET-1 scan, and then pembrolizumab for 2 cycles, interim PET-3, complete metabolic response, pembrolizumab, 2 additional cycles, and if PET-3 is positive, pembrolizumab, 4 additional cycles. So it's not yet recruiting. Primary endpoint is PFS at 1 year. And finally, some biomarkers in Hodgkin lymphoma, which are, for example, the metabolic tumor volume. So the metabolic tumor volume, it measures a combination of tumor size, tumor activity, and microenvironment. So you can see here 2 examples. On your left-hand side, a patient with a metabolic tumor volume of 28 milliliter. On your right-hand side, a patient with metabolic tumor volume of 410. And this metabolic tumor volume, as a prognostic factor, outperforms IPS and bulk definition. So we used to use the International Prognostic Score based on age, albumin, stage, hemoglobin, leukocytes, sex, and lymphocytes. And we used to talk about bulky disease more than 10 centimeter. And you can see that metabolic tumor volume outperforms these. So it was performed after 2 cycles of therapy, BRCAD or escalated BIACOP, for example, in the HD21 trial. And you see that patients, PET negative, of course, they did very well. PET positive, but with metabolic tumor volume equal to 0, they did as well as the PET2 negative, whereas those that had a metabolic tumor volume still positive had a significantly lower PFS. So PET2 patient with completely resolved metabolic tumor volume 2 had similar outcome to PET2 negative patients, whereas there was a higher risk of progression in PET2 positive patient with remaining metabolic tumor volume, or compared to PET2 negative patient with a hazard ratio of 4.4. And finally, we have the liquid biopsy, circulating tumor DNA, as a promising biomarker in Hodgkin lymphoma. So this is the total level of circulating tumor DNA are a marker for disease activity and correlate with FDG PET finding. So in a cohort study assessing PFS by MRD status, assessed by circulating tumor DNA after 2 cycles, you see the major increase from 62 to 92% of PFS for patient who became MRD negative after 2 cycles compared to MRD positive. So maybe there will be no need to expose patient to radioactivity of PET-CT scan, and this may be replaced. Of course, we need more studies and validation by just a liquid biopsy measuring the circulating tumor DNA on a blood sample. And this is an open label on your right-hand side, phase 2 study in patient with stage 1-2 Hodgkin lymphoma without bulky disease who received BV plus Nivo plus AD, the regimen that I mentioned, and look to the decrease in circulating tumor DNA after treatment. Thank you for your attention.
Thank you very much, Professor Bazarbashi, for really an inspiring and beautiful, comprehensive talk. I personally learned a lot, and it's quite incredible to see how in a curable disease we continue to do a lot of progress and trying to improve the outcome, but also minimize toxicities. And you have highlighted now this move from moving away from conventional chemotherapy to the modern approaches, especially with checkpoint inhibitors. And it is actually a special day today because some colleagues or most of you have heard about the Nobel Prize in Medicine, which has been awarded actually for those 3 researchers and pioneers who actually worked on immune regulation and regulatory T cells. So we're clearly in this environment, in this spirit of harnessing the immune system to control the disease. So we have a question. So we have a lot of questions. I don't know if we'll have time to take all of them. One question is about the very old patient above age 80 and whether you would recommend the Nivo AVD regimen in this population and whether you need some dose adjustment here.
For these patients, I think that they are not equal. You have patients above 80 who are fit to receive anthracyclines and those that are unfit to receive anthracycline. So those who are fit can receive a Nivo AVD. The dose of anthracycline is not very high. But in that case, I would recommend, although it was not mandatory in the SWOG study, I would recommend systematic GCSF to prevent febrile neutropenia. For patients who are unfit to receive anthracycline, BV plus Nivo has shown some good results. They are below those of Nivo AVD. We don't have published studies of reduced dose Nivo AVD, which will be an in-between situation for these very old patients. But I would say that it is exceptional. I mean, I haven't seen, we see quite a lot of Hodgkin lymphoma, and we are in Lebanon a population that is aging and older than other countries in the Middle East. I haven't seen a patient above 80 in the last 2 years.
Excellent. Thank you. So in the same line, we have a question about the use of single agent checkpoint inhibitors. In what situations would you use single agent? How does this fit in the global landscape of treatment?
So I wouldn't recommend single agent checkpoint inhibitor in frontline treatment of Hodgkin lymphoma because the complete remission rate is with single agent is around 30%. which is far below what we have as options. So currently, single agent checkpoint inhibitors are mostly used in the salvage setting in relapse patients, sometimes as bridge to autotransplant. Sometimes we combine a checkpoint inhibitor with chemo as bridge to auto. The same we do with brentuximab vedotin. And sometimes we use this, the most frequent use of single agent checkpoint inhibitor is for patients who relapse after autotransplant.
Excellent. Another question, actually, the use of checkpoint inhibitors in Hodgkin lymphoma is very exciting and stimulating a lot of comments and questions. So we have here a comment, and our colleague is asking about your opinion that he or she has observed that even in case of resistant relapses of Hodgkin lymphoma, actually, the use of checkpoint inhibitors can lead to disease stabilization and increase the survival. What are your thoughts? Do you agree with this comment?
Definitely, this has been proven many times. So when you look to the PFS and overall survival curve of the pivotal trials testing nivolumab or pembrolizumab in relapse after autotransplant, well, as expected, you see very good PFS and excellent survival for CR patient, but that you would expect. Then for PR patient, for example, or stable disease, you see the PFS curve going down relatively quickly, but the overall survival curve maintained. And even there are, in some situation, recommendations for what we call treatment beyond disease progression. So even patients on checkpoint inhibitors, when they have exhausted all other options, and you see the disease progressing on checkpoint inhibitor, of course, you will not be curing this patient, but continuing checkpoint inhibitor will result in a prolonged survival and better quality of life compared to stopping it even in progressing patients.
Excellent. Maybe we'll take another two questions maximum. What about the use of checkpoint inhibitors at time of relapse if they have been used frontline? Is this a good strategy, and how should we handle this?
So retreatment with a checkpoint inhibitor is feasible, and you can do it. So in general, for first relapse, we try to do the opposite of what we have done in frontline treatment. So if the frontline treatment included brentuximab vedotin, we would use a checkpoint inhibitor based salvage. If the frontline included checkpoint inhibitor, we would use brentuximab vedotin-based salvage. But then later on, if you have another relapse, you can reuse the checkpoint inhibitors. And sometimes we have patients, for example, in the post-allo setting, who were refractory to checkpoint inhibitor before the allo, and who become sensitive after the allo because we are not stimulating the same T lymphocytes. We are stimulating the donor T cells after allo. Of course, we have to be very cautious not to use it quickly after allo, not to induce steroid refractory GVHD.
Excellent. Thank you very much. Very clear answer. One last question, quick answer, because we're running a little bit out of time. After an auto transplant, so I assume this patient is in relapse of a 15-year-old girl with Hodgkin lymphoma, would you recommend consolidation maintenance with brentuximab or nivolumab?
Currently, the standard of care is consolidation with brentuximab vedotin based on the ATHERA trial. However, we have very good data, although preliminary and not randomized trials, showing excellent results with consolidation with checkpoint inhibitor, or if you have money, with combination of brentuximab vedotin and checkpoint inhibitor with unbelievable PFS, sometimes exceeding for these relapse patients what you see in frontline treatment.
Well, this is fantastic, Professor Bazarbashi. So as we close this insightful ICH webinar on first-line therapy of Hodgkin lymphoma, I think it is worth remembering that this disease remains one of the true success stories in oncology and cancer. This is a disease that has transformed from a fatal condition into one of the most curable cancers. And this achievement reflects decades of collaborative research, refined risk-adapted strategies, as we have just heard, and continuous innovation in treatment and supportive care. Yet, our mission is not over. While cure is within reach for most patients, we must continue to optimize outcomes, minimize toxicity, and ensure access to the best available therapies for all. This is our commitment for the AAA by the ICH: accessibility, availability, and affordability. And Hodgkin lymphoma stands as a powerful example of what science, teamwork, and dedication can accomplish. And this is an inspiration for the entire field of hematology. Wherever you are, please stay safe and keep well. This is the International Academy for Clinical Hematology around the globe and across the hematology field. Thank you very much.
Thank you.